Welcome to the program, Diagnostic and Pharmacotherapeutic Strategies for the Individualized Management of Atrial Fibrillation. My name is Jerry Naccarelli. I'm a professor of medicine and chief of the Division of Cardiology at the Penn State Heart and Vascular Institute in Hershey, Pennsylvania. I will be your presenter today for the program. This slide shows my disclosures and possible conflicts. This program is sponsored by the North American Center for Continuing Medical Education, LLC, an HMP company. This activity was supported by an educational grant from Sanofi US. So let's get started. This slide shows some of the learning objectives for today's program. First, we're going to describe the clinical and socioeconomic consequences of untreated atrial fibrillation, AFib-related stroke, and hospitalization. We're also going to employ a comprehensive diagnostic strategy, including assessment of stroke and bleeding risk for patients with AF. We're going to determine the risk-benefit profiles of available antiarrhythmic drugs for a given patient based on efficacy, safety, and patient-specific characteristics. We're going to evaluate the available clinical data surrounding favorable antiarrhythmic drug, anticoagulant combination strategies for the treatment of atrial fibrillation and the prevention of atrial fibrillation-related stroke. And finally, we're going to develop individualized AF management strategies that incorporate rate, rhythm, anticoagulation, and/or ablation therapies as appropriate. So this slide shows the prevalence of atrial fibrillation and the projected number of patients with atrial fibrillation in the coming decades. This comes from multiple studies, including a study that we participated in. And what all these studies show is there's millions of people that have atrial fibrillation in the United States. It's got about a 0.2% prevalence. But it also shows in the coming decades that there's going to be a doubling or tripling of the prevalence of atrial fibrillation. And so it's already one of the biggest heart rhythm problems that we have, that we treat on a daily basis, and it's only going to get worse over time. What is interesting is these numbers, although quite large, do not include subclinical atrial fibrillation, that is silent atrial fibrillation, which has been estimated to be as high as 40% with 3 years of monitoring. So if anything, these numbers may represent a underrepresentation of the true prevalence of the disease. Now, atrial fibrillation is a significant healthcare issue. As we just mentioned, it's about 2% of the population, affects 6 million patients approximately in the United States, again, that not counting the silent group we just talked about. It's associated with increase in aging and chronic heart disease, especially heart failure. It's frequently associated with other comorbidities, and AF complicates the management of those comorbidities, but the comorbidities also complicate the management of atrial fibrillation. It's associated with stroke, heart failure, and death, and there's an estimate of over 70,000 patients who die per year from the complications of atrial fib, many of these related to stroke. For as long as I can remember, it's the most common arrhythmia requiring hospitalization, representing hundreds of thousands of hospital discharges. It's the most common arrhythmia DRG discharge diagnosis in the Medicare population. This is much more prevalent in the aged population. The median age is 75 years. 70% of the patients are 65 to 85 years old. 84% are older than age 65. As I mentioned on the previous slide, the true prevalence of the disease is underestimated due to the lack of symptoms, or what we also call silent atrial fibrillation, which, again, if we go back to SPAF3, was 45% of the patients that were detected incidentally. This slide comes from the guidelines and just reminds us of some classification patterns of atrial fibrillation. This is important so that we have a shorthand that we're talking about the different forms of atrial fibrillation, and when you look at trials or in your own patients, how you would characterize them in your own patient chart. The first time one sees atrial fibrillation, it's often called the first recurrence, and the question is, if this is the first time that it was diagnosed, was this the first time the patient had it, or just the first time that it was seen and documented? Some of these go on to have no recurrence, although that is very uncommon. Usually that's only in what we call situational atrial fibrillation. The patient was so sick from their pneumonia or some complicated medical history that it triggered an episode of atrial fibrillation, and the only way you document that it was incidental or not recurring is to follow that patient over time, and if they have no recurrence, then you could, in retrospect, say it was truly situational. The majority of patients with atrial fibrillation have recurrent atrial fibrillation. These are relatively equal in size and buckets, depending on who you read, but the first is paroxysmal or self-terminating, and by convention, this is generally defined as terminating within 7 days, although the majority terminate within hours or probably less than 48 hours. Then there's persistent atrial fibrillation, and which is longer-standing atrial fibrillation, but it persists and for at least 7 days, but it can be continuous up to a year. And these are often patients that require an intervention to stop the atrial fibrillation, such as cardioversion. So one might argue, for example, the patient had atrial fibrillation for 36 hours, but it wasn't going away, and you cardioverted it, and is that persistent or not? Because it was less than 7 days, but because you had to actively terminate the arrhythmia, that would be considered a persistent episode. To make things a little more confusing, some people have added what is called long-standing persistent. This is kind of somewhere between persistent and permanent, in that it's lasted for greater than a year, but some people have looked at some of these patients and said, we're going to try to get these patients back in regular rhythm, although it's going to be difficult, and therefore it can't be permanent because by definition we're trying to get them back. This is a relatively small group of patients. And the final group is permanent atrial fibrillation, or what many of the older physicians may have learned in medical school is chronic atrial fibrillation. And this is a group of patients where sinus rhythm cannot be restored, or the physician and patient in a shared decision model made a decision that it's permanent because they're not going to try any more to get the patient back into regular rhythm. All these different subsets of atrial fibrillation can be present with or without associated structural heart disease. Now, there's a lot of conditions frequently associated with atrial fibrillation. The first point here is there's a definition of what is quote-unquote non-valvular atrial fibrillation, which is a little bit of a misnomer, but it's often used that non-valvular atrial fibrillation is most often defined as atrial fibrillation in the absence of significant valvular disease like rheumatic mitral stenosis, mechanical valves, but if the patient has minimal valvular disease, this is still considered non-valvular. So this is usually patients with serious valve disease, end-stage valve disease, mechanical heart valves. And one of the reasons for this distinction is many of these patients with advanced valvular disease or mechanical valves were excluded from the DOAC trials, and the DOACs are not approved in this group because of that. But if you look at the conditions that are frequently associated with non-valvular atrial fibrillation, it's hypertension and aging are two of the most important. But male sex, the males will tend to get atrial fibrillation at least a decade earlier than women. Women tend to live longer than men, so overall there's as many women as men that have atrial fibrillation, but they're usually a decade behind the men. Obesity, metabolic syndrome and diabetes, ischemic heart disease, heart failure, diastolic dysfunction, obstructive sleep apnea, physical inactivity, thyroid disease, and then generically inflammation, which is a little bit of a wastebasket. That inflammation obviously can occur in many situations. For example, the inflammation after pericarditis and things like that. But you could see that this is just even a partial list of the more frequent conditions associated with non-valvular atrial fibrillation. Now, if we talk about the pathophysiology of atrial fibrillation, this is just a cartoon to point out just a few principles, but to be honest, nobody completely understands the pathophysiology of atrial fibrillation, and we could come up with a list of 40 or 50 associations. But I already mentioned inflammation, and as shown in this cartoon, inflammation probably has a role in many patients with atrial fibrillation. This may be important in people, for example, with hypertension or vascular disease, and this can affect atrial dilatation and stretch, hypertension, which can cause left ventricular hypertrophy, or diastolic dysfunction, from people with heart failure, can add to atrial dilatation and stretch. There may be some inflammatory markers. This can cause mitral regurgitation, which makes the left atrium more dilated. And now you can get stretch-activated channels, dispersion of refractoriness, pulmonary vein foci and discharges, which are the common triggers for this. And all these things, and almost a circular loop, can increase one's vulnerability to atrial fibrillation. But as complicated as this slide is, it's still an oversimplification of what we think we know about the pathophysiology of atrial fibrillation. Now, how does atrial fibrillation present itself? It can vary, both between patients and an individual patient at different times. As determined by continuous electrocardiographic monitoring, patients with symptomatic atrial fibrillation episodes often have asymptomatic atrial fibrillation periods as well. This is why if we just look at symptomatic recurrence, we might be underrepresenting how effective a rhythm control strategy might be. And again, as we stated already several times, some patients will only have asymptomatic or silent atrial fibrillation. Symptoms may reflect most commonly rapid ventricular rates, and that could include dizziness, dyspnea, chest discomfort, rapid palpitations. Some of it may be second to the irregularity of the rhythm, again, palpitations, skip beats, some other hemodynamic symptoms. The specifics of the symptoms may guide the physician toward therapeutic choices and goals. Patients with atrial fibrillation often complain of fatigue, which is very difficult because everybody complains of fatigue. So when a patient comes in complaining of fatigue and they're in atrial fibrillation, is it related or is it not? And sometimes the only one can tell is to get them back in regular rhythm, and if they feel better, it was probably related to the atrial fibrillation, and if they don't, it was not. So often, if the fatigue is from atrial fibrillation, rate control can help in this situation, but often in that situation, rate control alone does not usually affect significant improvement in those patients. The biggest issue, of course, is thromboembolic events. So in all patients, this concern and the subsequent symptoms have to be considered, and this is one of the most pressing issues in assessing and treating your patients with atrial fibrillation. So if we talk about acute management of atrial fibrillation or chronic management, the pillars of treatment are listed on this slide. AF requires consideration of these multiple therapeutic options. Control of the ventricular rate is where we usually start. This is usually done pharmacologically. In refractory patients, AV junction ablation, which then would require pacing, is an effective strategy, but only used in a very select group of patients. Once one has good control of the rate, which is done for all patients, a decision then has to be made for rhythm control. Again, this is usually done with antirhythmic drugs, and we'll discuss some of the efficacy and safety of these drugs, but also patients are considered for catheter ablation procedures, and sometimes these are used in combination. As I already mentioned, as we're going through rate control and rhythm control, prevention of thromboembolism is key. And this is usually done with oral anticoagulants, whether the older ones such as warfarin or the newer DOACs. But more commonly in recent times with the approval of left atrial appendage devices, some refractory patients are having left atrial appendage occlusion, and then sometimes this is also just done surgically. I think the key thing, this often gets into an argument, of which is better, rhythm control or rate control and all these type of things, or antirhythmic drugs or ablation. We're going to talk about that in a few minutes. The reality is the selection of therapies has to be very individualized. Every patient is different. Every situation is different. So as you're working through these three common threads of therapies, you have to maximize the benefit and minimize the risk for each particular patient. As far as clinical evaluation, it's relatively simple, and many of these patients are presenting initially to a primary care physician, internist, or in the emergency department. And again, the treatment of AF might be dependent a little bit on the etiologic cause, the severity, whether it's reversible or modifiable, as well as patient factors, what's their embolic risk, what other disorders are going on. So a part of your assessment, which is appropriate for all patients, includes the following minimum: a good history, including family history, and specifically asking all the questions for the CHA2DS2-VASc risk factors, and thus creating a CHA2DS2-VASc risk score for that patient. The physical, looking for rate and blood pressure or murmurs or other type of things that may give you some hints of why the patient might be having atrial fibrillation. Baseline serum chemistries, and specifically a TSH, to rule out hyperthyroidism, which again does occur and has to be handled a little bit differently than what we just talked about, because now you have to get an endocrinologist involved in order to treat that. An electrocardiogram, whether they're in sinus rhythm or atrial fibrillation at the time you see them, to either document the atrial fibrillation, or to, if they are in sinus rhythm, look for hypertrophy, infarction, bundle branch blocks, and other QT prolongation, other abnormalities. An echocardiogram is extremely useful because even in a patient who you think has no history and it may be completely normal, it rules out myopathic disease, dilated left ventricle, significant murmurs, depressed ejection fraction, and also gives you a baseline for future reference, including the size of the left atrium. Stress testing is usually reserved to patients where you're suspicious of coronary disease or are old enough that you want to rule that out, not that the coronary disease is causing the atrial fibrillation, but if they have coronary disease, that may need a further evaluation, but it also would exclude some of the options of drugs that shouldn't be used in that situation. A chest X-ray is very useful to rule out pulmonary disease, cardiomegaly, and calcification that might make you suspicious of atrial fibrillation. And so you can see it's very simple things. And once you have these, usually you're ready to go ahead further. Now, we've already talked a little bit about the goals of therapy, and this just highlights some of them. First, you want to improve survival. That's been a little bit difficult to show in atrial fibrillation, except for obviously if you avoid stroke. You want to reduce the sequelae, so stroke is right up there, like number 1, 2, or 3 as far as one of your most important things you're trying to prevent. You want to reduce hospitalizations. Atrial fibrillation is associated with a large number of hospitalizations, and by keeping the patients properly anticoagulated, properly rate controlled, and minimizes recurrence with rhythm control, one can often achieve this. Improving symptoms. That's why the patient presented with you to begin with. Can you make them feel better from their symptomatic recurrences? Improve quality of life, which actually encompasses all the above, and restore atrial function and reverse the remodeling process. The longer you're in atrial fibrillation, the further the atrial fibrillation moves along things and advances. And so there's a lot of theory that by restoring sinus rhythm and maintaining sinus rhythm, instead of atrial fibrillation begetting atrial fibrillation, sinus rhythm begets sinus rhythm. Now, when we get back to our treatment options that we discussed a few minutes ago, rate control is, again, predominantly pharmacologic and includes the non-dihydropyridine calcium channel blockers, the beta blockers, and also forms of digitalis. As I mentioned earlier, rarely we have difficulty controlling the rate, and in those patients, a non-pharmacologic approach of catheter ablation of the AV junction and pacing is done. For maintenance of sinus rhythm, there's pharmacologic and non-pharmacologic. Pharmacologically, you can see there's a long list of drugs that are membrane active, including flecainide, propafenone, sotalol, dofetilide, dronedarone, and amiodarone. There are other class 1 agents that have been used in the past, such as quinidine, disopyramide, procainamide, that are very rarely used in the United States or even worldwide at this point. Beta blockers may have a small role in preventing some adrenergic-induced atrial fibrillation. Non-pharmacologically, catheter ablation represents the majority of procedures that are done, but there are some surgical ablation procedures or hybrid procedures with surgeons and catheter ablators, and there are some rare patients where pacing may be useful with pause-dependent atrial fibrillation patients with sick sinus syndrome, but mainly we're talking about catheter ablation in that box. As far as stroke prevention, we already alluded to the fact that pharmacologically, warfarin and the newer agents, dabigatran, rivaroxaban, apixaban, and edoxaban, is in our armamentarium. And I also mentioned that non-pharmacologically, left atrial appendage occlusion or surgical ablation of the left atrial appendage is employed in select patients. We're going to introduce just some cases here. We're not going to get in detail, but these are just typical cases and decisions that might have to be made in these patients. So for case 1, as an example, 66-year-old female, has a 1-year history of paroxysmal atrial fibrillation lasting several hours. She's minimally symptomatic on a once-a-day beta blocker. Her ventricular rate during AFib on her beta blocker is still a little bit on the fast side at 110 beats a minute. She has a history of hypertension. She's post-left carotid endarterectomy, and she has no history of heart failure, stroke, or myocardial infarction. She's also taking an angiotensin receptor blocker and aspirin. She has normal TSH, and her creatinine clearance is 66 milliliters per minute. An EKG at the time of the visit showed sinus rhythm with a rate of 78 and normal QT interval. Her echocardiogram was pretty normal with an ejection fraction of 55%. Her left atrium was minimally dilated. She had a stress nuclear study giving some of her risk factors and age, and showed normal perfusion and ejection fraction, no evidence of ischemia, so no known coronary disease. So this would be a typical patient, and now you have to make some further recommendations, and we could ask what those recommendations would be, but some of them in this patient would be she's not adequately rate controlled, because on her current beta blocker, her heart rate's 110, so one would need to address that. She's having paroxysmal atrial fibrillation, is still symptomatic with this, and one would have to consider adding a rhythm control strategy, given the fact that she does not have coronary artery disease. The drugstore is somewhat open. We'll talk a little bit later about the choice of drugs in a patient like this. And she has a high CHA2DS2-VASc score with her hypertension and her history of carotid disease, vascular disease. She's female. She's 66. She has like a CHA2DS2-VASc score of 4, and she's not on a proper anticoagulant. So all these things, just for beginnings, would have to be addressed. If we look at case 2, an 80-year-old man presents to you after moving to the area. He complains of dyspnea and exertion and fatigue. He has a 5-year history of what has been permanent atrial fibrillation, and his rate on a Holter monitor ranges from 76 to 148, but averages on the fast side at 120 beats a minute. Besides his age, he has a history of hypertension, but no other CHA2DS2-VASc risk factors. He's actually already on a calcium blocker for rate control at low dose and warfarin with the therapeutic INR. His AFib, his EKG in the office shows atrial fib with a rate of 120, no other abnormalities. His echocardiogram shows some mild hypokinesis and a mildly depressed ejection fraction and a mildly dilated left ventricle and left atrium. Again, what recommendations would you have for this patient? Well, the good news is he's anticoagulated and seems to be doing well on warfarin, so that's been already addressed before you saw the patient. This patient has permanent atrial fibrillation, and so all one is going to do besides that is just rate control the patient. Right now, he is not adequately rate controlled, and one would have to add or increase the dose of the medicine he's on, and one could hypothesize that either he has a mild cardiomyopathy with ejection fraction of 45%, or some of this could be a tachycardia-induced cardiomyopathy because he's been in atrial fib for 5 years with inadequate rate control. One could, maybe get better rate control at this point and then assess him down the line and see if that improves. Now, there have been many trials of rhythm versus rate control. FIRM is the main trial where we've learned from, but all the other trials have shown very similar findings. AF-CHF was basically a FIRM in heart failure patients. So to summarize a large number of trials, what did these trials find? Major findings. Rhythm control was not necessarily superior to rate control in terms of morbidity or mortality. This suggests that rate control is an acceptable primary therapeutic option in many patients. Again, that depends on the patient, as we talked about before. Patients with atrial fib and risk factors for stroke should receive anticoagulation indefinitely, even when sinus rhythm appears to be restored and maintained on pharmacologic antirhythmic drug therapy. Both strategies are acceptable primary therapeutic options, but rate control does not apply to all patients with AF because they were not included in some of the studies. Many of the patients, for example, patients who were very symptomatic might have been excluded from some of these. Patients who were symptomatic in spite of rate control, very young patients, patients whom exercise tolerance is important, patients in whom rate control had failed already, patients with a depressed ejection fraction, one might try to be more aggressive. Obviously, clinicians need to adapt to every patient situation and individualized therapy for each patient. If one is going to pursue rate control, this is from the American guidelines. If there's no other cardiovascular disease, traditionally beta blockers and calcium blockers, specifically diltiazem and verapamil, are used. If there's hypertension or HFpEF, heart failure, preserved ejection fraction, again, very similar, usually beta blocker, especially, but calcium blockers, then controlling both the hypertension and getting rate control. If there's left ventricular dysfunction, calcium blockers usually fall out because beta blockers are going to be used anyway to improve LV function and survival in those patients. And there's a role then for digoxin if beta blockers are ineffective. In COPD, mainly beta blockers and calcium blockers, but this might be a group where calcium blockers might be used earlier to avoid any bronchospasm. You can see underneath, amiodarone, which is a multi-channel blocker, can be used for rate control, but as a general rule, there's a concern, obviously, of using that drug because long-term therapy with amiodarone is associated with a lot of adverse effects, and that usually one can control it short of amiodarone, and then often, if pharmacologic therapy is not useful, an alternate strategy is AV junction ablation. Again, back to the rate control, rhythm control controversy. A typical rate control patient profile might be like the patient 2 we had, elderly, asymptomatic, AF is recurrent no matter what you do, they've had multiple cardioversions. Every time you try an antirhythmic drug, you either get a side effect or an efficacy, or the patient just prefers it. For rhythm control, the more symptomatic they are, the younger they are, no prior history of cardioversion, again, patient preference. As far as the guidelines, pharmacologic therapy can help maintain sinus rhythm in most patients with atrial fibrillation, and experts often recommend attempting rhythm control in most patients for starts, and then applying early interventions preventing new onset atrial fibrillation, progressive to permanent. And then if that doesn't work, well, obviously sometimes a fallback position is rate control. This slide shows the old Vaughan Williams classification of antiarrhythmic drugs. Again, many of these drugs kind of fall out of that classification. The class 1 drugs are predominantly the sodium channel blockers, and specifically for atrial fibrillation, we don't use the class 1A drugs essentially anymore, and almost all these patients are on flecainide or propafenone, which have the advantage of not prolonging the QT or causing torsade de plainte, but the disadvantage of not being used in patients with coronary disease. So because you're selecting patients and they don't have a risk for torsade de plainte, they're often used as an outpatient. The beta blockers we talked about, mainly used for rate control, the class 2 agents. The pure class 3 agents are agents such as sotalol and dofetilide. These are more IKR blockers, potassium channel blockers. These have to be used with some caution because they do prolong the QT interval, have some risk for torsade de plainte, and dofetilide specifically has to be initiated inpatient, and sotalol usually is. Then there are 2 drugs that are quote-unquote in the class 3 class because they're potassium channel blockers, but they're multi-channel blockers, amiodarone and dronedarone. These actually are a mixture of class 1, 2, 3, and 4. They're sodium channel blockers, they're beta blockers, they're potassium channel blockers, and they're calcium channel blockers. And these drugs, again, are multi-channel blockers, but because they prolong the QT interval, that they have extremely rare incidence of any torsade de plainte, are commonly used as an outpatient. And then the class 4 drugs are the calcium channel blockers. Again, these are limited to for rate control purposes, and then there's drugs like adenosine and digoxin that are also used, adenosine for terminating SVTs and digoxin for rate control and for its inotropic support. So specifically about antiarrhythmic therapy, what are our endpoints? The first thing is you have to remember AFib is usually recurrent, rarely lethal, so you have to keep your goals realistic. You want to reduce the frequency, duration, and severity of events, and you want to minimize the risk of treatment, in any way that you can. Therapy, as per the guidelines, must be selected not just on efficacy, because these drugs have about a 40 to 60% efficacy, amiodarone being on the higher end of this in comparative studies, but the safety. Can they tolerate the drug? So the highest tolerance is most of these drugs are very well tolerated. The pro-arrhythmic risk, I alluded to this. Drugs that prolong the QT intervals, specifically dofetilide and sotalol, one has to be very cautious in that regard. We avoid class 1C drugs in people with significant structural heart disease, coronary disease, myocardial infarction. Organ toxicity, amiodarone can inflame the liver, thyroid, the lungs. We usually reserve amiodarone for patients in whom the other drugs are ineffective. The effects on sinus node and conduction system, for example, if you already have sick sinus syndrome and sinus node dysfunction and you're trying to avoid a pacemaker, you want to avoid drugs such as sotalol or amiodarone that may slow the heart rate further, and that may be a case where dofetilide, which is a little bit more neutral in the sinus node, might be a great idea. Left ventricular dysfunction and heart failure. The safest data from the trials, and you'll see that from the guidelines, is with dofetilide and amiodarone. So again, it depends on the patient. This is a summary of multiple studies, and this is from an article that I published, but you could see amiodarone's in dark red, dronedarone in a lighter red, sotalol in a bluish color, and class 1C drugs in a pinkish color, and placebo in more brownish color. What this summarizes is what we know from multiple trials, that amiodarone has the highest efficacy, about 60% or so, in maintaining sinus rhythm over a period of time. The others are in the 40 or 50% range. So one could see this and say, well, maybe we should use amiodarone instead of the other drugs because it looks a little bit better. But as I mentioned earlier, we actually do it the opposite way, because amiodarone also has some difficult pharmacokinetics and the most concern of end organ toxicity. Another point that we consider in initiating the drug is most of the patients I see in my practice are in the outpatient setting. Can I safely initiate the drug in the outpatient setting? And as you can see here, the class 1C drugs, dronedarone and amiodarone, have some benefit in that regard. We are cherry picking the class 1C drugs a little bit. These are patients without structural heart disease. But dofetilide and sotalol are going to usually be initiated in hospital, and as I mentioned earlier, dofetilide really mandates that. So if you're in the hospital, that might change. If you have a patient and he's in the hospital, he's going to be in a few days, you have to initiate therapy. Maybe it makes a little more sense in that patient to initiate sotalol or dofetilide while you're in the hospital, because you have to do that anyway. If it's effective, terrific, and if it isn't, then you could, in the outpatient office, try an alternate drug that you don't have to readmit the patient. Follow-up protocols. This is part of the consideration of using an antiarrhythmic drug. Proarrhythmia may occur late, although it usually doesn't, but risk factors develop over time. Does the patient get hypokalemic, or they get renal failure, which could affect drug clearance? Amiodarone is an ongoing risk issue, and you have to monitor thyroid, liver function, pulmonary toxicity. Almost all the other drugs, you don't have to worry about this. If the patient develops permanent atrial fibrillation based on specifically results from the PALIS trial with dronedarone, I think most electrophysiologists would say the drug's not working. It may even have adverse effects. Discontinue membrane active drugs in those patients. Class 1C drugs, we already mentioned, you want to avoid in coronary artery disease, but a patient may be 40 years old and doing well, and now he's 60 years old. You need to keep an eye on over time, the patient may develop coronary artery disease, and you may have to discontinue an effective therapy. And whether you screen these patients with stress tests and things over time is an individual decision. Dofetilide and sotalol, keep an eye on the QT interval. These are highly excreted by the kidneys, about 90%. So renal function is very important. Dronedarone, the main thing to look for is, from the PALIS trial, is if the patient develops long-standing persistent or what you might consider a form of permanent atrial fibrillation, the patients don't do as well. They should then be discontinued or cardioverted back in if it works, keep them on it. Amiodarone, as we mentioned, there's a whole protocol for monitoring end-organ toxicity in those patients. Now, we've talked a little bit about drugs. What about catheter ablation? This is almost a talk in of itself, but to keep it relatively simple, the majority of atrial fibrillation that we see that's amenable to catheter ablation occurs because of pulmonary vein triggers. And what ablation does is targets the isolation of the pulmonary veins so that these triggers cannot get into the atria and start atrial fibrillation. And there's some more complicated ablations, including looking for other causes when this doesn't work. And when one does a pulmonary vein isolation, one is also doing some autonomic modification over time. Catheter ablation is very effective, as shown in this slide, and this is from a study published by Dr. Calkins. But it shows that as a single procedure, the success rate in this series, which was quite large, was about 57%. Multiple procedures, that is, if you do more than one ablation, you get over 70%. And then there is what I would call partial efficacy, single or multiple procedures where the procedure is done, the patient has recurrence, but now you can put him back. It's a hybrid therapy. You put him back on an antiarrhythmic that may not have worked before, or maybe even at half dose, and yet you get a good result. So that's not an inconsequential number of patients. The main indications for catheter ablation, again, it depends on the patient and the center, are symptomatic refractory atrial fibrillation, or patients that are intolerant of at least one of the antiarrhythmic drugs we discussed. In rare clinical situations, it may be appropriate as more of a first-line therapy. Selected patients with heart failure and reduced ejection fraction, there's increasing body of data from CASTLE-AF specifically in subsets of Cabana that these patients might do a little bit better with catheter ablation, especially given that these patients have a limited armamentarium in the pharmacologic realm. The presence of a left atrial thrombus is, at the time of the procedure, is a direct contraindication. And generally, ablation is also not performed in patients with really marked left atrial enlargement, but it can be done, with a lower efficacy and slightly higher risk. This slide summarizes a lot of data about catheter ablation, and the first is this procedure continues to grow rapidly. I think it's safe to say it affords a potential quote-unquote cure. I don't think there's any such thing as a cure for atrial fibrillation, but a good result in as many as 70-80% patients if you select them properly, especially if it's paroxysmal AFib with minimal heart disease in good centers. More than one procedure is often required. So if there's a 70% efficacy, you're talking up to 25 or 30% of patients may either require a second procedure, especially if an antiarrhythmic drug doesn't work. I highlight here one recent publication, one recent presentation that's adding to our knowledge in this area. The first is CASTLE-AFib, which was published. In this trial, catheter ablation of AF in patients with heart failure was actually associated with improved all-cause mortality and fewer admissions for worsening heart failure when compared to conventional standard of care antiarrhythmic treatment. This trial has several important concerns and is small size, so although it's very encouraging and I'm suspicious this is true, there's still data coming in. A much larger trial is Cabana. This trial has not been published yet, but it was presented at the Heart Rhythm Society, comparing, again, pharmacologic therapy to catheter ablation therapy. Some important findings were that there was a significant reduction in AF recurrence by ablation compared to drug therapy. On the other hand, ablation significantly reduced mortality and hospitalization by 17%, but compared to drug therapy. However, this was not by an intention to treat analysis, only on an on-therapy analysis. So some encouraging data there, but again, by intention to treat did not show, any improvement in those endpoints. And ablation did not significantly reduce the primary endpoint by intention to treat of all-cause mortality, all-cause death, and cardiovascular hospitalization. So keep an eye out for this. You'll probably see this in publication soon, and you'll probably hear more about this. What do the guidelines say? No structure. It depends. Do you have structural heart disease or don't you have structural heart disease? If you do not, then the drugstore is open, and amiodarone is going to be, only reserved for refractory cases. But you can see catheter ablation is right up there. And again, usually the recommendation, and what I usually do in my practice, is try one or two antiarrhythmics first. If it's effective, fine. If it's not, catheter ablation is there. By the time you're getting into a third or fourth antiarrhythmic, or you're going to amiodarone, for sure you should start at least considering catheter ablation. With structural disease and coronary disease, notice flecainide and propafenone are taken off the list. We usually would start with dofetilide, dronedarone, and sotalol because their efficacy is 40-50%, as we talked about, and they're safer to use than amiodarone, and they've all been safely used post-myocardial infarction. Again, amiodarone is a fallback if these don't work. Where catheter ablation fits in, is somewhere similar to the other group, but usually after one or two of the other drugs have been tried. Heart failure is a little tougher. The best data is for dofetilide. There's some mixed data on amiodarone. We usually start with dofetilide or amiodarone, but based on some of the recent data from Castle AF and some of it supported by sub-analyses of Cabana, we may see catheter ablation done a little bit more aggressively in that group in the coming guidelines. Now, an important area that we're going to finish up with is stroke and atrial fibrillation. It's the most common serious complication of AFib. All-cause stroke in patients is 5%. Over 15% of all strokes in the United States are caused by AF. 90% of strokes are in nonvalvular AFib and that are ischemic, and then 10% of patients that have embolic events may occur peripherally. Elderly patients, especially without any coagulant, have over a fivefold increase in the risk of ischemic stroke versus younger patients. And whether it's paroxysmal or persistent, this stroke risk occurs at a relatively equal frequency. Ischemic strokes associated with AF is more severe than stroke from other etiology. The stroke risk persists even if you're asymptomatic, and 84% of stroke patients with known AF are not treated with an anticoagulant at the time of their presentation. So it shows a lot of the issues. Mentioned earlier, it's very important to measure the CHADS-VAS risk scores. You get 1 point for most of these, 2 points for age more than 75, and 2 points for a prior stroke, TIA, or thromboembolic event. The maximum is 9, which can only be achieved in female gender patients. For a man, it's 8. And you can see the adjusted risk goes higher as you accumulate more points. What are the recommendations for anticoagulation? We already talked about the definition of nonvalvular atrial fibrillation. The recommendation is to assess, to do stroke risk assessment using the CHADS-VAS score. Shared decision making is important. What's the cost, the tolerability, the patient preference, drug interactions? If you take warfarin, do you stay in the therapeutic range or don't you? You could use other scoring systems, include CHADS-VAS, hemorrhages, HAS-BLED. They are useful for epidemiologically showing bleed risk, but they are not recommended for not using the drug, and I think that's very important. Aspirin, which has often been used in the past, is not very effective at all in this, and it's really been de-emphasized in the current guidelines. This is a slide from Freiberg showing stroke annual event rates, and you could see on stroke with no anticoagulant versus an anticoagulant, and each that the risk is reduced. If you look at thromboembolic events of any kind, which whether stroke or peripheral, again they're reduced. You're more likely to bleed if you take an anticoagulant. You don't, but you could see the overall bleed risk is relatively low, and intracranial hemorrhage is even lower. So there is some risk of taking anticoagulant, but it's quite small. Who do you treat? Basically, if you have a CHA2DS2-VASc score of 2 or higher, the guidelines suggest that the right thing to do is put them on an anticoagulant. The European guidelines actually come out and say it should be a DOAC instead of warfarin. If you're CHA2DS2-VASc 1, nobody knows what to do, and no therapy, aspirin, or an anticoagulant is reasonable. If you're CHA2DS2-VASc 0, the current recommendation really is neither. If you have a mechanical valve, these were excluded from the DOAC trials, and one should use warfarin until we have more data. Now, in spite of the obvious, this is from some guidelines, this is from the Pinnacle Registry, and it shows that basically half the patients in this registry who, based on a CHA2DS2-VASc score of 2 or higher, who should be taking a real anticoagulant or not. There's a lot of reasons for this. The fear that an anticoagulant might cause you to bleed, and there's kind of an over fear of the bleed, but an under fear of the stroke. You can see aspirin is used in a lot of these patients, and the myth that aspirin works, and people haven't gotten over that. Some of these numbers are improving over time, depending on a lot of work being done. But we have a lot of work to do, and this is probably one of the number one problems in atrial fib management today. Theoretically, if we were better about doing this, as many as 60,000 fewer strokes annually are possible. That is, if we got everybody who should be on an anticoagulant on one. And you could see the results are pretty striking. So hopefully, as we get better at doing this and screening patients and reminding doctors and physicians about this, we'll get there. Does warfarin work? Absolutely. These are multiple trials, showing that if you take warfarin and you keep a therapeutic INR, you will get a 2/3 reduction in the risk of stroke. And that's all we had until the last few years when the DOACs became available. This is a very busy slide, but shows the 4 major trials with dabigatran, rivaroxaban, apixaban, and edoxaban, all used prospectively against warfarin. And what you could see in red is where the trial was superior, in black where it was neutral, and there's a few in green there where it was inferior. To summarize most of these trials, they were all at least as effective in preventing stroke compared to warfarin. Some were better. As far as ischemic stroke, dabigatran was the only one that reduced ischemic stroke compared to warfarin, but all of them majorly induced hemorrhagic stroke, the most significant risk factor compared to warfarin. The risk was often offset by some numerical increases in bleeding by some of the drugs, not by, in the case of apixaban and edoxaban, the overall bleed rates were lower. These were usually GI bleeds, but offset by a lower risk of intracranial hemorrhage and therefore less mortality. So these drugs have a lot of benefit, are much simpler to use, and are continuing to grow in popularity. In spite of all this wonderful news, one needs to keep in mind there's restricted use in these populations that were not in the study, specifically people with significant renal impairment, pregnant women, prosthetic heart valves, and end-stage valvular disease. So in those patients, we still have limited data and they shouldn't be used. Now, once you start putting patients on multiple therapies, you worry about interactions. An example of one of these interactions is amiodarone has a major interaction with warfarin. A drug like dronedarone does not have very much interaction, and most of the others have very little to none. So this becomes, especially with the complex pharmacokinetics of amiodarone, when you have a patient on warfarin and add amiodarone, you have to really usually down adjust your warfarin dose. Amiodarone, dronedarone, verapamil, diltiazem are potent P-glycoprotein, and they can be moderate CYP3A4 inhibitors. They theoretically can increase DOAC blood levels, so keep this in mind. The good news is DOACs have a very wide safety margin, and there's not a lot of evidence of concern, but there is some package insert restrictions. Retrospective analyses of hundreds of amiodarone patients, for example, have not shown any clinical bleeding or embolic risk issue, although the theoretic issue is there. Drugs like dronedarone, which are a little newer, were not used very commonly in the trials. There's this potential concern. However, there's not been shown to be any clinical concern. In fact, in a recent study with apixaban, there was no increased bleeding risk. What about aspirin? This is from Averroes, where aspirin was randomized to apixaban, and I think it emphasizes the myth of aspirin efficacy. This trial had to be discontinued early because apixaban not only majorly reduced stroke and systemic embolism for aspirin, but actually had no increase in major bleeding compared to aspirin. So I think trials like this, and there's multiple other trials, have added to the death of aspirin in this subgroup of patients. As far as dosing of these drugs, you can read the package insert yourself, but there are restrictions based mainly on renal function, and it's very important to dose the way they were in the trials based on these renal numbers. And essentially, none of these were studied with creatinine clearances less than 30, although the FDA extrapolated dosing down to 15 milliliters per minute based on blood levels. There's a high-end restriction on adoctobay on patients with creatinine clearances greater than 95. Didn't do as well as other patients in the trial, and in their package insert, it suggests you should not use that in those patients. Finally, although the newer anticoagulants have been a major improvement in patient care, a lot of patients still have bleeding, or they take an anticoagulant and they have a stroke, and thus we have left atrial appendage occlusion. This is some summary data from a meta-analysis of the Watchman device, and you could see that this device does work, and there's some favorable numbers on all-cause death. Major bleed rates are neutral. Major bleeding, non-procedure related, actually favors Watchman. This is a growing area, but again, in general, this is restricted to patients who are candidates for anticoagulant, but either can't take them from a bleeding risk or take the drug and still have a stroke in spite of doing the right thing. These are the indications for the Watchman to reduce the risk of thromboembolism from the left atrial appendage in patients with nonvalvular atrial fib who are at increased risk because of their CHADS-VASc score and normally would take an anticoagulant. They're deemed by their physician to be suitable for an anticoagulant, but they have an appropriate rationale to seek a non-pharmacological alternative. And again, most of their comparative data is against warfarin, not against the newer anticoagulants, but this is a growing indication. So getting back to our patients, you could see, if you look at case one, given the information we shared, we already talked about, we would probably increase their rate control. This patient does not have any coronary artery disease. You would probably start with one of the drugs from the guidelines. In this case, if you're in the outpatient, probably either flecainide or propafenone or dronedarone. If they were ineffective, probably then go to sotalol or dofetilide. At some point in there, if it's not working, you might consider the patient for catheter ablation or amiodarone. And again, this patient would have to be appropriately anticoagulated and probably stop their aspirin. In case two, as we already alluded to, this patient has permanent atrial fibrillation. They have rate control, but it's inadequate. This needs to be improved. They're adequately treated with warfarin, it looks like their INR is therapeutic, but if the patient is having a difficult time in their therapeutic range, you might consider switching to a DOAC. This patient's not a good candidate for a rhythm control strategy because you've already kind of given up the ship on this patient. If the patient were to have a stroke in spite of adequate INR and warfarin, they might be a candidate for a Watchman device. So, as we mentioned earlier, it's all about individualizing patient care. AFib patients are extremely complex. AF may be infrequent or frequent, paroxysmal or non-paroxysmal, unassociated or associated with comorbidities, clinically apparent or subclinical, and unassociated or associated with markers of increased risk for thromboembolism. Thus, individualization of AF treatment based on current guidelines is very appropriate, and you got to weigh the risks and the benefits. Rate control, rhythm control, and stroke prevention remain pillars of care, and therapy to prevent stroke in high-risk patients is the highest importance. So we've covered a lot of information today. I really appreciate sharing this with you. So this concludes our presentation. Thank you for joining me. Please complete the post-test evaluation to receive your continuing education credit.